Awesome. Thank you, Isabelle. And welcome to our fourth session in the most fabulous 340B webinar series you will ever attend. We have hopefully built up your confidence and increased your functional knowledge of HRSA's 340B drug pricing program. We've hopefully made this program more digestible, understandable. And like I said, this is part 4, and we have one more session. Part 5 will be on May 5th, so save the time and day for that session. And at the end of the presentation, we'll also share a registration link for that session as well. And like Isabelle said, any questions that either haven't been covered so far or don't get covered in this session, make sure you guys let us know, because we want to make sure that this TA is tailored to everyone's needs. And today is all about 340B implementation. So I'm going to run through a review. We're going to have a famous quiz, a pop quiz, and then we'll start some review, and then we'll have our great panelists today present to you about what they're doing with the 340B program, how they're utilizing it, and what program operations look like for them to, again, hopefully give you perspective, knowledge, and empower you to possibly duplicate or implement your own program. And I just went over all of this. We're going to review the basics, talk about roles, registration, contract pharmacies, compliance, and then we'll highlight some awesome local programs who are leveraging the 340B program for viral hepatitis activities. Right, going to launch this poll. All right, your questions for today. First question. Okay. Can everyone see the poll? Can you see the poll? Okay, awesome. First question, covered entities aren't responsible for the operations of their contract pharmacies, true or false? Second question, a covered entity can have multiple contract pharmacies, true or false? And finally, what makes an organization 340B eligible? Awesome.
Are you seeing?
Yep, I'm seeing the results. I've got 17 out of 38 of you have voted, and when I end the poll, I think it'll share results.
Okay, well, that's exciting.
Yeah, that also, I guess, prevents you from going with the group answers. You don't have your peers to help guide you to the right answer.
Ooh, that's a shame.
Excellent. We've got about a dozen of you still needing to vote.
Also, I put the link for registration, part 5, in the chat box.
Awesome, thank you. All right, our polling has started to slow, and I'm very proud of our cohort. Let's see if I share results. Okay, so most of you got all these questions right. So the first question is false. Contract pharmacies are acting as agents for covered entities. That means that covered entities retain responsibility to prevent diversion, duplicate discounts, and also maintain audible records and meet all other 340B program requirements. So I'm glad that lesson has stayed with you. Number 2, again, the majority of you got that one right. The answer is true. Multiple contract pharmacies may be needed to meet the needs of patient populations. And for 3, again, most of you got this one right as well. So the correct answer is B. A 340B qualifying provider receives qualifying funding or support that comes from a federal funding source authorized by the Public Health Service Act, which is Section 318 for viral hepatitis, HIV, and STD programs. So I'm so proud of you, little class.
Me too.
Excellent.
I really am.
Okay, let's stop sharing those.
Also, we didn't, but that's okay.
We didn't what?
We never saw the results.
Oh, I'm so sorry. I pressed the share button. Okay, now who's the boomer?
Not you and not me.
All right. And if you missed our first 3 sessions, like Isabelle mentioned, we're on YouTube. The links are on the slide, also shareable. But if you need a refresher or you need to go revisit one of our sessions, they're available to you. And we're going to take some time to review the basics again. It sounds like everyone's got a pretty good understanding. Just a reminder that this program was created in '92. It requires drug manufacturers to provide outpatient drugs to eligible healthcare organizations and covered entities at significantly reduced prices. It was enacted by Congress and signed into law. This is a law. Eligibility is dependent upon receiving federal funds that are authorized by certain sections of the Public Health Service Act. And again, viral hepatitis, HIV prevention, and STD programs all fall under Section 318, which is the STD 340B designation. And another reminder that covered entities must have a financial relationship with a qualifying Section 318 program. That means direct financial support or in-kind contributions. Once an organization is a covered entity and they've met the eligibility of receiving Section 318 funding or in-kind support, they also must serve eligible patients. There's a three-part patient definition. The first is that the covered entity has an established relationship with the individual and maintains records of the individual's health care. The individual receives their health care from an employee or paid contractor, and the responsibility of care remains with that organization. And the covered entity provides a service or range of services, which is in line with the grant funding that has been provided to the entity that makes them 340B eligible. And again, another pro tip, you can find statutory authority in any NOFO. All Section 318 grants are eligible for the 340B drug pricing program. You can do a Control F and find your statutory authority in any NOFO. So if you're curious or wondering or want to know how many NOFOs you have that are authorized by Section 318, super easy, open that PDF, Control Find, and look for that statutory authority. Health department roles in the 340B program. Again, a health department may be a covered entity themselves, or they may be administering funding to subgrantees that make the subgrantee 340B eligible. So a health department role as an administrative perspective is to ensure subgrantees know about the 340B program, that health department administrators provide guidance of what is considered a service within the scope of each CDC NOFO, understand how subgrantees are meeting the patient definition, review policies and procedures, set clear expectations regarding oversight and compliance, be familiar with how subgrantees are purchasing medication, update contracts and agreements to account for all of the 340B considerations that we've learned about throughout the series, as well as revenue, be aware of registration and recertification periods, and also provide needed documentation for registration and recertification. And that includes grant numbers and NOFO numbers that they might need. Also, state health department administrators will need to verify to Office of Pharmacy Affairs that their subgrantees are in fact 340B eligible and that they are receiving either direct financial support or in-kind contributions. State level administrators also will need to notify HRSA, Office of Pharmacy Affairs, if a subgrantee is no longer receiving funding or in-kind support and are no longer eligible for the 340B drug pricing program. What are not health department roles? A health department administrator is not responsible for enrolling subgrantees into the 340B program. Health department administrators should not serve as a subgrantee's authorizing official or primary contact. You don't ever want to attest to another agency's compliance. You're not responsible for creating policies or procedures for anyone besides your own self. There is no requirement to audit 340B compliance. If that's an additional requirement that you want to add, great, but there's no federal requirement for that. And also make sure you are not taking all of their revenue and you have negotiated and discussed what revenue generated from this program should be used for. There's 4 annual registration periods for the 340B program. So once you or your subgrantee determine they're eligible for 340B, it's really important to understand registration and recertification. So the 4 annual registration periods happen every year, the first 15 days of the calendar quarter. It doesn't matter if it's a business day or a weekend, it's the 1st through 15th of January, April, July, and October. The register button on the Office of Pharmacy Affairs website is only accessible during these open registration periods. And additional considerations to keep in mind is that Office of Pharmacy Affairs takes 3 months to verify registration and to activate a registration. So covered entities may not purchase or dispense 340B drugs until their registration becomes effective. So in your planning, make sure you account for this 3-month time lag where registration is approved by HRSA. And ideally, each location, each covered entity would have a unique database entry. This limits audit liability and compartmentalizes operations. And this might not work for everyone depending on how your organization is set up, but a consideration for covered entities to have. And of course, 340B drug pricing program, you need to actually acquire the drugs, acquire the medications, and that is done through wholesalers or contract pharmacies. And like we talked about in our pop quiz, covered entities are responsible for ensuring compliance, even when using contract pharmacies. So just remember that covered entities always retain the responsibility to prevent drug diversion, duplicate discounts, maintain auditable records, and meet all other 340B program requirements. And when we talk about program requirements, the compliance elements that you want to keep in mind are 340B policies and procedures, contract pharmacy agreements, Office of Pharmacy Affairs information system records, prevention of diversion, and prevention of duplicate discounts. All right, I'm going to pause there. I sped through that review so we can make sure we have plenty of time for our panelists, but I just want to pause if you guys have any questions about our review material or the basics or anything we've covered in part 1, 2, 3.
I have no question report from the chat box, but absolutely give folks a few minutes.
Yeah, there was a lot of speed talking.
It was a lot of content. It was, but it's okay. And you did a great job.
Hopefully I'm not a broken record by now.
No.
But well, I can't say that I didn't teach you guys these principles.
This is true. This is true. And it's worth repeating, especially just speaking on my own behalf. So, oh, Heather said helpful review. And I agree.
Thank you, Heather. Okay, well, with that, let's get to the really exciting part of today's presentation. So I am going to invite our California, Iowa, and Utah friends to the stage, and we'll go in alphabetical order. So we'll start with California, but if you guys wouldn't mind introducing yourselves, and feel free to turn on your camera so we can see your beautiful faces. I see Rachel. Hey. Anybody else feels comfortable sharing their face, that'd be great as well. And we'll go, like I said, in alphabetical order. So if California wouldn't mind starting off with introductions, and then we'll follow that up with Iowa and Utah. And then after introductions, we'll dive into my interview questions. But we would love to hear everyone's name, organization, and role in the 340B program.
Okay, I did leave the option for if y'all want to unmute yourself. Dang it. Or not. Ooh. Okay, how about now?
What would happen if I asked to unmute?
That's what I did as well.
Oh, there, I asked to unmute Rachel and it worked.
Okay, let me.
Okay, I think I'm unmuted now. Good morning, everyone. I'm Rachel McLean. I'm the Chief of the Office of Viral Hepatitis Prevention for the California Department of Public Health. Let's see, I'm sort of like the viral hepatitis prevention coordinator, basically, for California. And my role in the 340B program, honestly, has mostly been kind of being along for the ride. My colleague, Laura Kowaleski, in the STD control branch, who's on the line, has really been, she and one of my other colleagues, Layla, who's redirected to COVID right now. The three of us have been working together with the California Department of Corrections and Rehabilitation to confer 340B eligibility to them. But Laura, I would say, is probably has the highest level of 340B expertise. And I've really been just kind of learning and focusing on the hepatitis C aspect of the collaboration. And to be honest, we did not coordinate on our end before this. I apologize. I didn't realize that my Office of AIDS colleagues were going to be here. So Ann Nakamura is also with the California Department of Public Health. If you could unmute her, as well as Laura Kowaleski. And I'm trying to think if there's anybody else from California. But
I think my colleague Becca is on.
And yeah, Becca from ADAP, Becca Parks, is on the line as well. We're a big state, we have a lot of people. So anyway, that's who I am in my role in our collaboration. So our collaboration has been through the CDC STD grant, but focused on HIV, STD, and hepatitis C. Yeah.
So
Great.
I can go next if that's okay. So I'm Ann Nakamura, and I'm with California's ADAP Office of AIDS. We are in the what I call the sibling branch for our partnering branch, which is the AIDS Drug Assistance Program branch, where they administer the program, and we are in their sibling branch, and we provide evaluation and monitoring and fiscal analytics. And so my role and my team's role is using the 340B data, our anticipated income or revenue, to project and assess the fiscal health of the program and to make projections. So we do a lot of predictive analytics, a lot of stretch exercises, sensitivity analyses, and all of our cost neutrality assessments. I am on the ADAP Crisis Task Force, which is tangentially related, negotiating drug prices, and my section provides some guidance and policy guidance and in terms of best practices for invoicing and adhering to the requirements from the federal and also our state requirements.
Awesome, thank you. And Becca, you're our last California friend to do intros.
Hi there, Becca Parks. I work with Ann. I'm a fiscal and contract counterpart within the Office of AIDS ADAP. I'm also in the Office of AIDS itself, not just ADAP, but I also do policy and legislative analysis. And I work with Rachel some on that, those efforts. And so I'm here getting information and learning as much as I can, so hopefully integrate our programs.
Awesome. And did I miss anybody else from California that wanted to introduce themselves? Okay, let's move on to Iowa. Iowa, if you wouldn't mind, name, organization, and role within the 340B program.
All right, well, thank you for having me. My name is George Walton. I am the STD program manager here at the Iowa Department of Public Health. So just like so many of you, that means I wear a lot of different hats, but probably what's most relevant to this discussion is my history with the 340B program here at Iowa. I've been primarily focused on our STD safety net clinics as things got rolling or got started here several years ago. But I also provide support and expertise to the other programs in the Bureau, which would include our viral hepatitis program and some of the things we'll talk about today and how we're utilizing 340B to help further some goals with that program as well. I guess the other thing I'll mention about my history with 340B is I feel like I've come a long way and I've learned a lot over the years. I remember when I first started in this role, my position had actually been vacant for about a year and a half due to a hiring freeze. And one of the first things my supervisor did was take me to this office, show me this filing cabinet with just reams of 340B medications reports that have been mailed in that nobody had looked at for years. And he's like, you need to fix this. So it took a while. I think we're in a better place. But the other thing that I always say with 340B is the more you know, the more you realize you don't know. So I am always learning. It's why I'm excited to hear from some colleagues today about how they're doing things as well. I do also want to acknowledge Biz McChesney is on the line here with us as well. She's our HIV prevention and viral hepatitis program manager. So she and I work very closely together in these matters.
I think I unmuted you, Biz.
You did. Thank you. Hi, everyone. Thanks, George, for introducing me. I'll just say hello. George is really going to be representing Iowa today. But I am Biz McChesney. I'm the HIV and Hepatitis Prevention Program Manager. So I work closely with George as we implement 340B activities related to HIV prevention and PrEP, and also our viral hepatitis program. Thanks for having us.
Awesome. And has Dina made it on yet? Anybody from Utah Department of Corrections on the line? All right. Hopefully she will join us soon. I have a reminder out to her, so hopefully she'll jump on. Let's start our questions because I don't want to waste any minute of time to hear from our fabulous panel here. So really, I want to hear different perspectives, and let's start with our first question. And I think Rachel prefaced this in her intro, but tell us what grant is authorizing your 340B covered entities in your state. If it's not you and your organization, perhaps your correctional facilities or your other subgrantees, what grant are you using and why did you choose that grant? And maybe raise your hand and Isabelle can figure out who to unmute if you can't unmute yourselves.
I think folks can.
Okay.
Dang it.
Should we maybe just leave everybody unmuted? I don't know, that's going to affect our audio. Who wants to go first? Raise your hand.
Okay, did it work?
Hi, this is Rich. I think I answered the question, but we're using our STD Peach grant. And I think the reason for using that is we do have an established 340B program in collaboration with local health departments to support local STD clinics. Laura, who's on the line, has been managing that program for a number of years. And yeah, I think my temptation is to want to answer all the questions. So I'm just gonna stop there.
And then George, did you say your STD grant was also your authorizing grant?
That's correct, yes. So we use STD Peached as well to authorize just about every 340B site in the states that, at least that we have purview over. And our reasons, I'd say, are similar to what Rachel mentioned. We had an existing program in place, and I think we'll get more into this in a bit here, but in terms of correctional facilities, we actually were already working with one of the facilities for our chlamydia gonorrhea program. So they were getting support in that way. So it just made sense, or it seemed to be the simplest path to go down that road, expand it a little bit, and see what we could do to get some medications available for hepatitis treatment.
Awesome. And I'll speak for Utah, since Utah Department of Corrections hasn't joined us yet, that it's also the Peached grant that is authorizing the Utah Department of Corrections to be in the 340B program as well. So let's move to our second question. So Rachel, George, Beckett, and Ann, if you want to jump into, but what does your qualifying grant support look like to your subgrantees in your correctional facilities? Is it actual funding, in-kind funding, both? And if it's in-kind support, talk to us about what that looks like for you guys.
Sure. Maybe we can just sort of like do a rotation. So in terms of in-kind, so we provide in-kind support to our state prisons. We are not giving them funding because they already are separately funded in the state budget, including for hepatitis C treatment. The in-kind support was really modeled after, like I said, the existing STD 340B program that's been going for many years. So we provided condoms as in-kind support, and the condoms were purchased with STD Peach grant. The like part of me that doesn't use acronyms, I'm trying to remember what Peach stands for. It's like prevention and STD prevention and control for health departments, I think is what STD Peach stands for those of you on the line that are not part of your STD program. It's like the core STD grant for state health departments. So we provide condoms that are purchased with STD Peach dollars. And those were, our prisons actually have a condom distribution program. So we sent them some condoms to sort of supplement that program. And we also provide technical assistance and we have sort of like monthly or quarterly coordinating calls. And then we also have, as part of our technical assistance, like clinical trainings on STD, HIV, and hepatitis C clinical guidelines from CDC. And we try to make sure that at least, one of the clinical guideline updates are provided by staff who are funded by the Peach grant, if that makes sense. My position is not funded by Peach, so if I provide technical assistance on Hep C, it doesn't really count, if that makes sense. But we do have clinical training staff who are funded under Peach.
Okay, should I jump in?
You should just jump in. Yep. Don't wait for me to cue you, George. You just go for it.
All right. So yeah, similar. We too use in-kind support for our correctional facilities to confer that eligibility. Ours is focused around our safety net testing program for chlamydia gonorrhea testing. So the funds that flow from Peach, as we've mentioned here, the federal STD grant, go to our state hygienic laboratory to pay for those test kits for chlamydia gonorrhea. And then those test kits are made available to certain sites in the state that we designate, and in this context, a couple of correctional facilities with our state Department of Corrections. And so that confers the in-kind support. So again, similar to my earlier response, I mean, we had this infrastructure in place. We used it very commonly outside of our correctional facilities. And we had used it before with one of the facilities that ended up being a part of this. But again, we just kind of expanded upon it. So it was a pretty, I'd say short jump to get to that. I guess the other thing I'll mention is that, for our safety net testing program for chlamydia gonorrhea, we support that with federal funds. We also support it with state funds. So there is some mixed funding there. But of course, for this context, the fact that we're using some of the federal STD funds to support the testing for that program is really what made that in-kind support possible and conferred that eligibility to the facilities in the Department of Corrections.
Awesome, thank you. And Rachel and George, since you are supporting your covered entities with in-kind contributions and support, what does your agreements look like? Is anything in writing? And if so, how and what components do you feel are the most beneficial, and how do you audit proof your covered entities, your correctional facilities that you're supporting?
So I don't remember how long, I don't remember when the conversation started, but I want to maybe just back up and say that like when the folks at our Department of Corrections, they went to a conference and they saw a presentation from Iowa and I think in Alaska, and they got really excited and they reached out to us and said like, oh my God, other states are doing this, we should do this. And at first I was like, oh my God, prisons are not allowed. I think the other states are breaking the law. This is not kosher. And so we went to our office of, we dug deep into what other states were doing, reviewed all the laws and everything, talked to our legal department, and then ultimately realized like it actually was okay to do any of this. And that process of like freaking out was like 6 months at least. So I want to just sort of preface this by saying that like, if you're starting from a place of sort of like uncertainty, first of all, Erin has already probably like solved most of that because she's so awesome and has taught us all so much. And that it's okay to just sort of start from exploratory place. So first we did the research and freaking out, and then our legal department was like, actually, it seems fine. And so then we had at least 6 months or a year of conversations back and forth with the prisons to like really explain to them everything that Erin has been explaining to us, which is like, this program is complicated. There's a lot of rules. You have to like do a lot of documentation. And so Laura, who's on the line, my colleague Layla, and I had monthly calls with the corrections department to sort of like shepherd them through the process of understanding the rules of the program and supporting them in developing policies and procedures to figure out how they were going to implement the program. And during that process, we also established an MOU between the Department of Corrections and the Department of Public Health. And that has now been signed, and we have like an official MOU that lays out sort of our role, which is, as we said, conferring eligibility, providing material and technical in-kind support, and kind of keeping track of things. But as you said in your training, it's really kind of up to them to ensure compliance. But we did go back and forth with them multiple rounds. I would say several months of going back and forth with the edits on their policies and procedures. Because, for example, in some of the earlier drafts, the language was kind of vague in terms of who was going to do what. So we tried to just make really sure that it was clear who was really assuming responsibility for keeping track of all of the requirements of 340B and stuff like that. So anyway, they have policies and procedures that we have reviewed in detail with multiple back and forths until we felt comfortable with it. And then we have an official MOU as well.
Awesome. I really appreciate you normalizing that freak out and that steep learning curve, Rachel, because it is totally normal. Everybody goes through it. George went through it. I went through it. Everybody else at a state health department goes through it. So I think just normalizing that and also creating a safe space with your peers. Like, I've asked George really stupid questions. I've asked NASDAD really stupid questions. And so, yeah, just you don't know what you don't know until you don't know it. So I really appreciate peers and colleagues, one, acknowledging that and also helping each other through that. So thank you for that. And then George, what does your agreements or contracts look like, and what components do you feel are most beneficial in your agreements outlining that eligibility?
Yeah, well, before I start that, I'll echo the freak out thing. As you were speaking, Rachel, I was going to say, well, 6 months doesn't sound like that long at all for a freak out. That actually sounds pretty quick. So yeah, I've definitely experienced that. And I think, we all start various aspects of the 340B program, and we're more comfortable with some than others. And I'll be honest, there are still some things that other states are doing that not related to this. I'm like, I'm still nervous about that. So I still call upon others for some reassurance and coaching for other aspects of 340B. But anyway, to answer the question, so we have a memorandum of agreement with it's 2 facilities in the state that we're working with, the State Department of Corrections. I didn't really mention this before, but these 2 facilities kind of serve as medical hubs for our State Department of Corrections. And I keep saying state intentionally because it really is them that we're working with on this. Our local or county departments of jails and correctional facilities, they're separate, that we don't really have that kind of relationship with them, particularly for hepatitis treatments. But anyway, I just wanted to be clear about why I kept referring to them as the state facilities. But this MOA that we have, it's a pretty standard one. It's the one that we use with all of the sites that participate in our safety net STD or chlamydia gonorrhea testing program. There really isn't much that's different there. There is another a form or an enrollment agreement that we use with other sites. We actually don't use that with our Department of Corrections because this other agreement we have is more when we're providing financial support for the medications. And in this, the way we have it set up, really all we're doing with the Department of Corrections is conferring the eligibility with the in-kind support, and they are purchasing the meds on their own with other funds at 340B prices. So really, we just have this one agreement. And you know, what I would say is most beneficial is it furthers the goals of multiple programs in our Bureau, right? So, you know, when this started, you know, with the Department of Corrections, this interest, you know, I think it was similar to some of the things Rachel was saying. My supervisor had been in a meeting with one of the medical directors in the Department of Corrections. He'd heard some things, wanted to learn more about it. And he was very interested in expanding hepatitis C treatment among his population because, you know, I think he recognized that there were several missed opportunities. And we had this audience that we knew was infected with hepatitis C. They did routine testing, and they were just having trouble getting them treated because of the very high cost of those medications. So, you know, we started some conversations there about, you know, again, this existing relationship that I mentioned before with one of the facilities, and how could we leverage that? How could we expand upon that? So we brought in the second facility, and kind of circling back to the way I started this response is, we're able to make sure that folks are getting sexual health assessments, and you know, if there is a need for other tests, for whether it's chlamydia, gonorrhea, syphilis, HIV, whatever it would be. You know, they can get that testing as well. And then if they're diagnosed, the treatment. So I find it a great way to further integration for programs within our Bureau. I know that's something that we talk about a lot in HIV and hepatitis and STD, but this is one reason why I was so supportive of moving forward with it, is because, you know, we can make sure that folks are getting additional testing or proper testing for other STIs while helping folks who need HCV treatment get that and work towards cure, since we have these medications now. That's been fantastic. I guess one other thing I'll mention that's beneficial, again, generally with how we have this testing program set up, is we do get additional data, right? So in a standard surveillance program, you get all these pieces of data for persons who test positive. We do get some additional data for persons who test negative, just the nature of how we have this set up. So that's helpful as well. You know, there's a lot you can learn from data or information on folks who test negative. We can look at positivity rates and things like that. That's, you know, been more focused on our STD side, but in any case, I think that has been helpful as well.
Awesome. You both touched on a few critical aspects. One, that MOUs really outline what the state level program is giving to the covered entity, which is really important to demonstrate that in-kind contribution. So whether that's technical assistance, condoms, testing services on their behalf, whatever that is in an MOU, you want to make sure that it's not just what they're doing for you, because as state level administrators, that's usually what we're worried about, is what are they giving us? What are they giving us? But in this instance, a state level administrator would really need to outline what they're getting from that authorized Section 318 funding. And also, I love, George, that you really highlighted that intersectionality of all of our grants, because whether you're an HIV program administrator, a viral hepatitis program administrator, or STD program administrator, All of the concepts are the same. Everything that you've learned in this webinar series is the same. And I also love that, CDC uses PIXI, Program Collaboration and Service Integration. Like that is just seared into all of our minds being CDC grantees. And this 340B program and also implementation is a perfect opportunity to implement that. And also, like George, that you said, this is an opportunity to get additional things. Is that additional data, additional reach, additional people served? What are you getting to learn? This is a leveraging point. You should never necessarily hold the program hostage, but you should also make sure that there's a public health benefit happening. As the administrators of this federal funding, you want to see the biggest impact made. You want to see the scope of that grant implemented. You want to end viral hepatitis. You want to end HIV. You want to end STDs. Whatever grant that is, I think leveraging that opportunity is also very strategic. So thank you for touching on that as well. Okay, let's hone in a little bit on viral hepatitis activities and also the patient definition. So how do your correctional facilities or your subgrantees leverage the patient definition? How have they operationalized it? And what's your role in monitoring the program and helping them really stay compliant? It's a big question.
So I guess one caveat that I would say is that our partnership is still fairly new. So it really was in October of 2020 that the state prisons were officially enrolled as 340B covered entities. And so it's all still fairly new. I think the prisons are starting with HIV treatment because it's more of a sort of smaller and well-defined population. Obviously, Hep C prevalence is about 20% in our prisons. And so that's a much bigger program. But the patient definition is, as George mentioned, receiving a sexual health risk assessment, because that's a recommended service in the STD clinical guidelines that are tied to the PEACH grant. So it's very clear. But then once someone has received that, then, as you said in your training, they can receive any testing for, HIV, STD, hepatitis C. The prisons already do opt-out testing. So this is just kind of in support of that. So that's the covered, that's the patient eligibility. And then in terms of our monitoring, I mean, honestly, I think I would almost defer to my colleague, Laura, about that. But I think it's just again, like I said, we have regular calls with them to coordinate what we're doing. We have quarterly technical assistance sessions, and then each year, the entities are going to have to re-enroll and maintain their eligibility. But I think some of this remains to be determined. What's interesting is that, I didn't answer the question about the potential benefits. I mean, I think in addition to, just addressing HIV, STDs, and Hep C in our prisons, this week we have an outbreak of a really nasty bacterial infection in one of our prisons right now that's related to injection drug use. And so the prisons have been asking me for hepatitis C education materials that are specific to people that are incarcerated. And a lot of stuff that's out there is really outdated. It doesn't talk about the new medications. And so I'm starting to think already about what I want them to do with the 340B savings, which is not totally up to me. But so I think there's just a lot of potential uses for the savings. Our prisons are already distributing naloxone. They're already doing medication-assisted treatment, but I think those things could be expanded, for example. And the area that we're the most excited about, even though it's very theoretical and, we haven't figured out what it would look like yet, is right now, in terms of the HIV care cascade and even Hep C, the prisons are treating 8,000 people a year in California for hepatitis C, which I know is bigger than most state prison populations, but for us, that's just a drop in the bucket of our state prison population. They're doing a lot of great treatment. The HIV care cascade is actually really excellent in prisons. And then when people get out, they fall out of HIV care and everything just kind of falls apart. They are at high risk for overdose and their outcomes are just not good, because there's no continuity of care between our prisons and the community. And so one of the things that that the pharmacy folks have been talking about is really wanting to use the savings to, for example, put people on PrEP when they're on their way out of prison, put them on long-acting medication-assisted treatment. When there's an injection for PrEP, that would be even more amazing. Give people condoms, I think we should give people syringes, naloxone, all of that stuff. So I think that's one of the things that we're really hoping to develop. It's not in place yet, but I think there's the potential to save many, many millions of dollars given the size of our state. And so it's just very exciting thinking about all of the possibilities. And then, just this past week with all this stuff going on, I'm really pushing our prisons to distribute syringes in the prison. There are places all over the world that have syringe exchange programs in prison, but there are none in the US. And also to, have a safe tattooing program to prevent Hep C reinfection. I mean, the irony is that we have good treatment access in our prisons, but there's a lot of acute infection. There's a lot of reinfection because people have no way of injecting safely, So, and I think, this is me just dreaming, but I think if we have a lot of savings, then maybe we could start a harm reduction program in the prisons, who knows? So anyway, lots to ponder and dream about.
But you're recognizing the potential and figuring out how to leverage that potential and operationalize that potential, which I think is really important. The Utah Department of Corrections had a 500% increase in treating viral hepatitis thanks to the 340B drug pricing program. You see huge savings when it comes to HIV medications and Hep C medications. There's obviously a lot of cost savings with azithromycin, ceftriaxone, and bicillin, but really the huge amount of savings is coming from your HIV and Hep C infected populations in correctional facilities. It's a long-term chronic condition, and that's a monthly reoccurring cost. So millions, if not billions of dollars will definitely be saved. Okay, George, it's all you. Tell us about patient definition, operationalizing, and compliance.
Certainly. So as I referenced before, the patient definition is met through sexual health assessments. So we worked with the Department of Corrections when they were kind of getting things set up. And I guess I should mention too, our work with them isn't that old. They, officially came on in the second quarter of 2019. So it hasn't been that long. But at any rate, they had a lot of questions about, how do we ensure that somebody meets the patient definition, what counts as a sexual health assessment. So we too had some back and forth with them through a couple of drafts of their policies and protocols, but pretty quickly came to something that we all agreed on. So yeah, if there's anybody who, they feel that maybe benefit from hepatitis C treatment, for example, obviously those individuals would have a full sexual health assessment at a minimum. And of course, more than likely, they're going to require some additional testing, especially if there's some suspicion that they need hepatitis C treatment. So there'd be testing there if it hadn't occurred already, or additional testing to figure out viral load and things like that. But of course, there may be other things that they identify during that visit that we've referenced before in terms of added benefits for other STIs that they may benefit from testing from. So all of that, as Rachel mentioned as well, falls within the scope of the grant, the STD Peach grant, that federal grant, that sexual health assessment. So, I'd say once we kind of worked out how they were going to word that in their policies and procedures, it's pretty simple to say or determine or get somebody to become an eligible patient. In terms of compliance, so, I will say at this point that largely has fallen on the Department of Corrections. As I said, we had some good interactions beginning about their policy and procedures and how they would implement those. but we haven't done a lot of work with like directly following up with them at this point. We have had some discussions about that. So I keep referencing, the other piece of the program that's bigger that we're more used to on the STD side. And we do have some pretty regular, I'd say sophisticated, thorough ways to check compliance with those sites. And there are ways that, we've thought about to adapt that for the Department of Corrections. It would need to be a little bit different because, as I referenced for those other sites, we're providing some more support around the costs of medications. We're not doing that for the Department of Corrections. But in a lot of ways, I think it may actually be simpler. When I think about how we've implemented and worked with the Department of Corrections, it is in many ways more straightforward than what we've done with our STD clinics, if you will, that are part of that safety net program. I think it's more set up the way that was originally envisioned for 340B, basically that you are working with this entity to confer eligibility in whatever way, and then a lot of the subsequent steps fall with that covered entity. So that's largely how it's been with the Department of Corrections. So I guess to sum it up, I would say we had a pretty heavy hand in developing those initial policies with them. I think there's more potential for working with them for ensuring compliance. And I'll say, not even so much, or I should say not only because we're interested in doing that at the health department, they've expressed interest in that too. This nervousness that we've talked about, the freaking out, they have that as well. So, they feel like they're doing a good job, but I know they would welcome us going in there, checking things out, doing a mini fake mock audit, and giving them some reassurance. Obviously, this last year with COVID kind of put a pause on any of those thoughts that we were having. But I think, those are things that we'll explore as things start to relax a bit with COVID over the next year here.
Awesome. Thank you, panelists. I also just want to call out the parallels between correctional facilities and public health. There's just so much overlap and so much healthcare that happens in a correctional facility that people may not have an opportunity to receive until, unfortunately, incarcerated. So thank you for highlighting all of those points and, again, bolstering our confidence that if you can do it, we too can do it. We just have a few minutes left in our presentation, our hour together today. So I wanted to make sure that we have any time for questions if we have had any. Isabelle, come in through the chat. Okay, cool. Same resources that I always give you guys: HRSA's 340B drug pricing program, Hepatitis, update on 340B eligibility, 340B health. There's some contract pharmacy FAQs, and also auditing tools, policy and procedure templates, and other tools that Apexis has gathered for covered entities. And to just summarize our conversation here today, that public health partnerships are crucial in reaching vulnerable population. Patient definition implementation can look different for Section 318 STD covered entities. Also want to highlight that just because the STD grant was leveraged in these examples doesn't mean that that precludes the HIV grant or the viral hepatitis grant. All the principles are the same across the grants. How you implement that patient definition is dependent on the scope of the grant. And also that 340B medications stretch limited resources, including Department of Correction and prison budgets, as far as they can go, and improve medication access for incarcerated patient populations. And Rachel and George did a really great job of highlighting the real world examples on that. And our next and final webinar is on Wednesday, May 5th at noon. We're going to be talking about health equity and the 340B program in relation to health equity and working towards health equity, and some principles that as state level administrators, we should always be keeping in mind when serving our populations and our jurisdictions. So any questions? We have 2 minutes and we have George and Rachel's beautiful faces up there. So if there's any questions you would like to ask me or Isabelle or Rachel or George or Becca, anyone else, feel free to chat them at us.
Get a lovely comment from Jean Smith. Once again, very helpful. Well, thank you.
Helpful is my middle name.
Okay, well, we have a minute left, but no questions. Oh, Thaddeus said, thanks, this was great. Smiley face.
Thanks, Thaddeus.
I agree, it was great. Thanks again to our colleagues from California and Iowa for joining us and for your expertise. And we do constantly lean on them. So we very much appreciate not only your technical expertise, but just your general demeanor and your willingness to share all of the knowledge and work that y'all are doing.
Yes. And also I would just like to add, California and Indiana were so great to, or sorry, Iowa, sorry, George, Iowa, were so great to join us today, but they're not the only jurisdictions doing this. Like we mentioned, Alaska, North Carolina, Indiana, other jurisdictions and other correctional facilities, like Rachel mentioned, this is a conversation happening in pharmacy groups. This is a conversation happening at different conferences. It's not specific, you know, it's not in a little box. It's a national movement. It's a national correctional facility thing that the information is spreading, the utilization and the peer-to-peer TA is happening in other groups, not necessarily just in our state health department groups too. So with that, we'll conclude our presentation.
Absolutely.
Thanks, guys.
Thank you.